Then there's this debulking component, which essentially is removing tissue. In a lymphedema patient, especially if the lymphedema has progressed over a number of years, there's a lot of swelling and there's excess fat and tissue in the limb. Sometimes, limbs can be double the size compared to the other limbs. So we try then to reduce the size of those limbs via liposuction, fairly aggressive liposuction to get the limb down, and then that leaves a fair amount of lax tissue that we need to, almost like for cosmetic cases, we need to remove the excess skin and to contour the leg nicely in such a way that it resembles the other side, or that it sort of symmetrizes with the other side. In your mind, you can imagine that just by removing all of that fat and fibrous tissue, it's not a permanent thing. You remove it, but you didn't address the lymphedema. So as time goes on, the lymph will still then build up and you will get swelling again. So in situations like that, we combine the debulking with a physiological component. So after the liposuction and contouring of the limb, usually 6 to 9 months later, then we do a lymph node transfer so that we can add a physiological component, so that the limb can, after being reduced, at some point form new lymphatic connections and be able to drain the lymphatic fluid by itself. It does need a lot of care and attention, and you really need to work closely with a lymphatic therapist, because they need lots of massage and compression therapy. It's not something that we do and then all other therapy stops. There's quite a process, but generally patients do have fairly good results. There's significant reduction in size of the limbs, and pain and discomfort, and because of this, because of the swelling, they struggle with normal activities of daily living and grip strength to open bottles and getting dressed, and there's quite a few issues, but all of that greatly improves with surgery.